Yeah.
Good afternoon, Dr. Liu. I'm so excited to have you on here. I have been wanting to ask you to come on as a guest for a while, so I'm happy that we're finally doing this.
Thank you, Brittany, and really happy to connect with your fan base and your audience.
Yeah, I know everybody's just going to eat all of this stuff up because this is such a question I get so often is where that myo component comes in as far as jaw surgery patients go pre and post. And we're going to dive into all of that good stuff today. But before we do that, let's have you share a little bit. I know everybody probably already knows you for the most part, but give us a little bit about your journey and how you just got started in airway.
Yeah, thank you. So my intro to sleep science in general, I actually started as an undergrad, and that's because Stanford uniquely has that course called Sleep and Dreams, started by Bill Dement, who started the whole field of sleep medicine. Love one of my favorite quotes that he writes in his book. He says, "As late as 1970, the practice of medicine ends when the person goes to sleep."
Mm.
Super, and I would argue, and today of course we're starting to enlighten everybody, but the practice of dentistry or oral health also stops when the patient goes to sleep. So it was fascinating. I mean, at that time it was like, yeah, he might be right. We don't know how we're certainly not, our brain is actually, if anything, more active during sleep. How do we breathe when we're sleeping? How do we digest? How do we actually never knew. So anyway, that was an awesome course, which then I promptly forgot all about until I trained as a dentist and then as a physician from UCSF, finished oral maxillofacial surgery, and then did ENT surgery, focus in sleep surgery, trained with Bob Riley, one of the pioneers for the whole field. So ironically, it kind of came back full circle, and it brought me back to the field. And I was at Stanford during a very incredible era. I had Christian Gimino, CG, two doors down. I got to operate with Riley, and we trained a generation of fellows. And so it was a really dynamic phase. I was introduced to myofunctional therapy by CG actually around 2015. Um, didn't know anything about it, totally honest, prior to that. But it has really impacted a lot of my work subsequently. And last year I moved down here to South Florida, now building out a fully integrated medicine, surgical, dental, a myo, just trying to really integrate to the best I can all that I know.
Awesome. Oh my gosh. If we can just like clone you and put one of you in each of our states, I think like that would be like a myofunctional therapist's dream.
Thank you.
And I'm really excited to hear your perspective, surgically, the role that you feel that our oral and facial muscles play in a successful outcome in an orthognathic case.
Hmm. Yeah, one of the things and it's not just, when it comes to surgery, just the whole field of sleep breathing in general. It's quite incredible because I remember years ago, whether it's my ultrasound research or many other realms in this field, I would ask folks this question, because they're like, I'm studying the airway, I'm making a new oral appliance, I'm making a new hypoglossal nerve stimulator,
Mhm.
and then I ask them, so what do you think the airway is? And it tends to catch people by surprise. I mean, it's like folks devote their whole careers to it. Um, is the airway that black stripe, that we see on imaging? I mean, it can be.
Mhm.
Um, are we in the business of doing anything in that black space? Tough to say. And almost no one would share the perspective, I have, which is the airway as we know it is is the muscles, right? That surround that lumen.
Mhm.
And so ultimately, whatever it is that we're doing, it's
Mhm.
a muscular outcome in the end. And once you start to look at it that way, a lot of the longitudinal nature of the condition makes a lot of sense. So, anyways, it is all about muscles. At the end of the day, that's what we do. We're in the business of optimizing muscle function.
And I remember we were talking earlier, or this might have been we were messaging back and forth, but you had said how airway surgery is really muscle surgery.
Hmm.
Yeah. And if you
Absolutely is.
yeah, can you I know we talked about you sharing some videos. Can you kind of just break that down a little bit for us? Because
Absolutely.
I feel
Absolutely.
like there's such a disconnect, I find, at least, and talking to other
Yeah.
myofunctional therapists and getting other surgeons to really understand where our role and the importance of our role comes,
Hmm.
for a successful outcome, and not only successful outcome of the actual surgery, but like especially retention and stability years down the line.
Yeah, absolutely. Yeah, you know what we'll do? We'll continue to chat while I just share a few
Yeah.
videos to play in the background. But yes, what I was hoping to do, let's see, is
Oh,
to just kind of show a lot of muscles. So
yeah. So
here
for
we are.
anybody just listening to this for now, please visit the episode on our YouTube channel, The Myohygienist, and you'll be able to see everything that we're gonna get to be seeing right now.
Yeah. So, first and foremost, I mean, if we're talking about breathing and particularly breathing during sleep, okay, or if you're already in the business of treating sleep disorder breathing, what are we really in the business of treating, right? And folks will, throw out these very academic terms like loop gain and arousal thresholds and, muscle responsiveness, etc. But I get it. Those are academic, cool. The thing is, they are all mechanisms that contribute to sleep apnea, sleep disorder breathing, but there's no way of treating them. So let's just kind of focus on what we can treat. And when I say we here, by the way, I'm referring to all clinicians. So whether you're sleep medicine, whether you're a surgeon, whether you're a myofunctional therapist, the only thing that we can treat is that one mechanism called the peak rate, right? We can change the negative pressure required to collapse the airway. And that even in itself is so hard to visualize. So I break it down to two very simple videos. We are in the business of treating collapsibility. And if you're the pediatric airway, it's more about obstruction. They don't necessarily collapse. It's a little bit too short for that. But let me just play this video here. And this is so what you see here, right? The scope is you're past the nasal passage, you're looking down in the pharynx. This is dexmedetomidine mimicking the closest we can get to stage 2 sleep. And you look at the adult collapsible airway on that side. So we're in the business of addressing collapsibility. But what's collapsing? It's the upper airway muscles. Okay. On the pediatric side, there it's more of those kissing tonsils. Okay, showing that similar sort of lateral pharyngeal wall collapse that tends to make things worse. And the other thing, though, not to take away from another very important aspect, is flow. Okay, because now this set of videos is gonna show that the pharynx themselves are not collapsing, but because of airflow patterns, you can see that on the adult side you have epiglottis collapse, and on the pediatric side it might show up more like laryngomalacia. But so we're in the business of treating collapsibility and airflow. Okay.
Mhm.
And irregardless, um, and of course, we only show the dream outcome. And, but in a perfect world, this is every one of our patients, right? We start with this highly collapsible airway or airway muscles. And then we have this really stable one. Same guy. This happens to be a guy after jaw surgery. But
Mhm.
again, right? This is how whatever treatment we render, this is our goal. And this is
Mhm.
why I say it is all about the muscles, because fundamentally that is what makes up the airway.
Mhm.
The part of the airway that we're treating, right? Above the vocal cords.
Yep.
Yeah.
These videos, they're just so awesome. And, like you had said earlier too, like we as myofunctional therapists, we're treating the muscles all day, every day, but to be able to like visualize it in this sense is really, really cool.
Yeah, that was one of the things so after CG introduced, and I'll show you another set of videos, but after CG introduced me to myofunctional therapy, then one of the first things that came to mind was, well, wait a minute, what if while the patient is doing these exercises, we put a scope through and see what the muscles are doing, you know, uh, internally, maybe for the lack of a better word, but what the airway muscles were doing. And so, it took a while to really, I'll be honest, we tried it. We never really systematically published it. But I share the same idea with very good colleagues in Brazil. Now, Brazil is an incredible place when it comes to myofunctional therapy. And so with my colleagues there, we did complete phase 1 of this study. So I'll show you what they did.
Cool.
So you can see that. So that's that thing going through, her nose, right? That's the scope. And on the top, you see sort of up higher on the nasal, pharynx, and then down on the hypopharynx. And so again, just doing, I guess, that lingual palatal suction, exercise, and then looking at these differences. Or not difference, but looking at the movement of the pharyngeal wall, right? And so this is a nice paper. She actually, so Esther Bianchini, she actually has all these different exercises and videos all set up. And, the goal really is, well, which one of these exercises is doing what for the muscles? And so, we may have a targeted approach, like we always try to do, in terms of precision care.
Wow, that's incredible.
I'll show you similarly here. I'll show you this one here. That's quite interesting. So first, let me show you this, right? One of the first things that and this is one also kind of the aha moment. Okay. I was the first to show the before and after of sleep endoscopy after MMA surgery patients. Because when you look at the X-ray or the CT scan, people kind of tend to be focused on, well, it was a thin black stripe, the airway, and then it's a big fat, black stripe afterwards. But it really isn't saying a whole lot. But if you look at the before and after, so take a look at this, right? So on the top, before, after, bottom, before, after. And this is only 6 or 8 weeks after. It's insane. So
Wow.
what you see is that the soft palate and the lateral pharyngeal wall are immediately much more stabilized, right? Let me try to play that one again. And then the thing is now, I'll tell you what's really interesting about that publication. So this was 2016. What I wrote at the time was that, well, we have very predictable muscle outcomes at the soft palate and lateral pharyngeal wall, but the tongue, I said, response was variable. And so, I would kind of travel, and then people would actually cite that paper. They not knowing I wrote it, and they say, but the tongue response is not as predictable. But what I tell them is, what the mistake, or not the mistake, but the caveat is, that's only 6 to 8 weeks after MMA surgery.
Right.
Even if you don't have myofunctional training, that tongue tends to get stronger. And if you were to do myofunctional training, actually a year later, the tongue will also move as it should, driven by the genioglossus muscles. And so, anyway, it's just, the things that you pick up over time, but you see the stability there. And let me show you the myofunctional therapy of someone after MMA surgery. So here's a gentleman, and he's doing that tongue curling, right? So that he's curling his tongue, and look at the way it's pulling the lateral pharyngeal wall. So as the tongue's doing what the tongue is doing, you can see that the pharyngeal wall is pulling with it. Now I keep focusing on the lateral pharyngeal wall because collapse there tends to, give the worst outcome, the most difficult type of sleep disorder breathing to treat. So I always kind of focus on exercises that'll work out the lateral pharyngeal wall. Okay. Now, historically, surgeons used to do procedures where a lot of the soft tissue muscles were excised. They were just cut away, right? Dude snoring, let's cut off the soft palate. Not what we do anymore, but that used to be the model. And I'll show you what happens to the muscles of a patient where they have done that. So this young gentleman had, unfortunately, all the soft tissue muscles kind of done in that old school way. Okay. So you just imagine excision of all these muscles. Now, when you ask him to move his tongue, sure, his tongue still moves. But you'll notice, even though his tongue moves a lot, the sidewalls don't come with you, right? They're not connected. So these are also tough patients for you guys to treat.
Right.
because you can have them move the tongue all you want, or the soft palate, or the lateral pharyngeal wall, but they don't move as a system
Mhm.
as you're trying to expect them to do. So you can
Right.
see, so the tongue's moving separate from everybody else. So
Mhm.
imagine if he were sleeping, right? This wouldn't work because the whole point is the tongue moves, everybody dilates, and we're breathing. Okay. So compare this again versus the previous video where all the muscles are preserved, and see, even with minimal movements of the tongue, you're pulling everybody else. Okay.
Right.
So this whole thing is a muscular gig, and
Mhm.
you don't do anything to the muscles, meaning you don't want to, cut into the muscle, mess with the muscle, move them around randomly. You want to do everything you can just to strengthen them. And again,
Right.
that's one of the biggest the lessons I learned in the last 10 years,
Now, what
is
do you
muscle
feel like
strengthening.
are some of the biggest benefits you've seen firsthand from cases that have gone through myofunctional therapy along with their surgery and ones that haven't?
Well, so there's two sides to that.
Mhm.
There is definitely the patient understanding the sort of the psychological aspect of it. Maybe we'll
Mhm.
do that second.
Mhm.
Um, but in terms of physiologically, right? Well, what does that do for patients? Well, a lot of times, let's say you have. So let's talk about, say you have a narrow maxilla patient. Tongue never really moves up. I always say, tongue never goes to the second floor of the house, right? That space is unused. Now, uh, even after expansion, it doesn't mean that the tongue knows, oh,
Mhm.
there's a room now and I need to go use it, right? So it's kind of a wasted opportunity. And if you're talking about relapse and all, well, there's your perfect setup for a relapse. Um, and so the advantage of doing myofunctional therapy beforehand, and let's just, I'm just call it prehab as opposed to,
Mhm.
rehab afterwards, but they get it. The patients know, I can't do that now,
Right.
or I know what you mean by a weak, or not so active tongue. Um, and they also learn the exercises so that, because, post-op, I mean, we want to get them back exercising quickly, but,
Yeah.
they're like, yeah, I just had a procedure and, I'm uncomfortable. And now you're teaching me this rehab thing. And, it's just, it's not a great setup. Now,
Mhm.
uh, the thing is this, if you think about it, like I said, that's why I say it's always like the best way to think about it is think about it like athletes, right? So, if an athlete suffers an injury and you have to do something, right? The most important thing is after the procedure is the rehab. Now, why is
Mhm.
it they don't have quote unquote the prehab? Well, they don't do they're already super strong, right? They're muscular, they're strong. So they're already prehabbed. Okay, they're cool. They're really good. So after the procedure, they just focus on the rehab, and that's okay. But for our patients, the muscles are weak. So
Mhm.
so if you don't do some prehab work, then they're really, really weak after you do the procedure, really weak. And then you're playing a lot of catch up, right? You're playing a lot of catch up. So it's about optimizing the patient, optimizing it the best we can.
Mhm.
And by optimizing includes many things, right?
Mhm.
Lower the BMI, right? Get them back on CPAP for just a little bit, just to decrease the inflammation and the reactivity.
Mhm.
Um, do the prehab myo, do the procedure, and then get them back, onto therapy. And I think, I mean, as a baseball fan, as a kid, for example, if a pitcher throws out their arm and they undergo this thing called the Tommy John surgery, where you essentially take a muscle to replace a tendon, it used to be kind of a death sentence. It's like, there goes your career. Today,
Mhm.
folks routinely throw it out, they come back and they throw 2 to 3 miles
Mhm.
faster, right? And I can tell you, I don't think the surgeon have gotten much better or the procedure has changed by a lot. But what
Right.
has happened is the rehab science
Mhm.
has to have been amazing, right?
Mhm.
And that's what we need to get to from an airway perspective. I do not believe that we will make too much more of a headway in terms of surgical procedures. I mean, there's still a lot to improve, but that's
Mhm.
kind of it. I think the bang for the buck is going to be the prehab and the post-hab protocol.
Now tell us a little bit, like, how, this is, aside from, I'm sure there are more surgeons like you that exist, but there are certainly not a lot that we as myofunctional therapists tend to be in contact with. How can we have these conversations better with our surgeons to explain to them, and both, right? Because sometimes I feel like the rehab component is easier to be like, okay, I could get behind that, but the prehab component, not so much. So how can we better communicate with our surgeons?
Yeah, I've never found it easy to communicate with surgeons. I certainly have a tough time communicating with surgeons myself. Um, I don't know, maybe they'll say the same thing about me. Um, so we might just have a phenotypic problem to start,
Mhm.
okay? But look, ultimately, we really want the best outcome for the patients. And I will say that, I mean, even all this stuff I had to learn. I was never trained. I mean, the way we were trained is you move some bones around, or if you're dealing with muscles, you're doing, facelifts or facial muscle things. You're not really thinking about the airway muscles.
Right.
And gosh, tremendous value with the prehab assessment. For example, the patient I showed you where none of the muscles were connected. Well, you better know that. Because when that
Mhm.
patient, let's say if that patient went on to get jaw surgery and comes back to you and you're like, hey, nothing's working. Well, first of all, the muscles were all disconnected from the get-go. I mean, if I were to separate your biceps from your triceps, yeah, they may still work, but they're independent of each other. And that cannot be, right? That
Right.
cannot be. Then all the stress is on the joints still in that case. So um, I think I think even if like some of these videos, I just feel like seeing once you see it's so hard not
Right.
to think about it just as any reasonable person.
Mhm.
And I think if surgeons now the other disconnect, of course, is that the jaw surgeons tend not to scope, and the people who scope tend not to do jaw surgery. So there's also disconnect even from fundamentally from a surgical end, and then the people who operate on the jaws don't work on the nose, and the people who operate on the nose don't work on the jaws. So
Mhm.
so I think that the all of our collective responsibility is to bridge that. Is
Right.
kind of to bridge that. And I would say if you can, in your collaboration with your surgeon, if you can have one or two cases where you're both involved in the pre and the post process, and you have a good airway endoscopy and you're seeing it. I mean, in the case of awake endoscopy, the patient's seeing it. It's very
Right.
powerful. They're doing these exercises, and I show them. I said, "Look, you're working out these muscles," and they're like, "Okay." I mean,
Yeah.
in fact, it's somewhat empowering. When they subject you to
Sure.
get surgery, unfortunately, they do feel a little bit helpless because, well, it's in the surgeon's hands. But then when they can see that, oh, okay, but I can do these exercises to help my own cause, I
Mhm.
think psychologically
Yes.
that
Because you were
adds.
you were going to talk about that component too. There is
Yeah.
really such a big psychological component when it comes to jaw surgery, and so yeah, let's talk a little bit about that.
Because you're the coach, right? You're actually the rehabber. You're the person whom they want to see, right? They
Mhm.
want to realize, oh gosh, I'm really weak. Okay, this surgery has all the benefits,
Mhm.
and the true benefit really is the changes in the upper airway muscle. Otherwise, why are we doing this? I mean, even
Right.
for facial aesthetic purposes, we want to balance that in
Mhm.
terms of improving, the airway. I mean, jaw surgery is not a trivial surgery. It has side effects, including, numbness of the chin that is almost unavoidable to some degree.
Mhm.
So the benefits better outweigh the risks. And one thing we've learned is, okay, well, all these things have to be factored in. Now, if I had a coach, and the coach is telling me, all right, do these exercises, and I know it, and then after surgery, the coach can just encourage me to start doing it, right? Instead of trying to learn it post-op and then doing it, it's not great. And also after surgery, you start doing it, you feel stronger. So that
Right.
motivation kicks in.
Mhm.
It's really like having, I mean, it's a bit of a luxury, and that's why there's not enough of you guys either. But it's like it's like a trainer. I mean, and someone's vouching for you. It's powerful that part of care.
Yeah, I think, I get it so often from my patients post surgery. It's like some of them are so there's always certain foods that they are scared to eat. And I will
Mm.
tell them, bring them into your session. Like, I'm going to help you through this. And they're like, I don't know what to do with my mouth. Everything is foreign here.
Mm.
Everything feels weird. The way my teeth line up, my jaw, my tongue, I have no idea
Uh,
what my tongue is doing.
yeah.
And it's like, and they'll say to me, like, oh, I wish I saw you sooner. And I know we were talking about this. Sorry, my golden retriever right here is like his head
No.
is up. You see his little tail flip flopping in the back. They'll always say to me, like, why the patients will say, why isn't this standard? Like, I can't imagine have going through this and not having you, along for the ride with me. And like you said, that psychological component, that's one of the reasons I feel that prehab is so important because I'm checking in with those patients on the regular from the day that they have their surgery, on all ends, they need that support person. And I'm happy to be that for them, if, of course, if they need it. So I think that that is so important. And I think, as you said, just having these open conversations with the providers and those videos, I think, to your point too, once you see it, you can't unsee it. And tell me if I'm saying this correct. So not all patients are getting the endoscopy prior to.
Well, correct, because again, you got to think of, the vast majority of surgeons who do jaw surgery, right, are trained as oral maxillofacial surgeons. And so the teaching there, of course, is, restoring the bite, which is the occlusion, right? And I mean, even factoring the airway in there is a very new thing. So one thing I do want to say is, while for the patient they say, hey, this really makes sense. Why didn't they see you sooner? But we also have to kind of recognize that this line of thinking and you and I, this approach, this is defining new standards of care. I mean, of course, it is not standard. Since it makes so much sense, I hope it will become standard. But I will tell you, right? I mean, previously at Stanford, there were also real challenges there as well. Not all your speech therapists buy into myofunctional therapy as well.
Right.
Myofunctional therapy also has a focus on restoring proper function, not compensating
Mhm.
function with incorrect anatomy, which is another approach. And
Mhm.
they both have their own place. But
Mhm.
we're trying to restore form and retrain function. That's what I always say. Sleep apnea surgery or any facial skeletal surgery or even soft tissue, right? It has to be restorative rather than reconstructive. When we say reconstructive, we're thinking there. Okay, yes, I get it. There's a tumor in the jaw, and you cut that tumor out, you put a leg bone up to replace it. Right, we have to do that. That's not what we're trying to achieve here. What we're trying to achieve here is to restore proper function, and
Mhm.
that way we're trying to restore form. So don't invent surgery. Don't do things that it doesn't work with the natural development of the human face and airway. But that whole thing has to be factored in. I would just say that it's going to be a new standard of care. I just think that it's easy to adopt because, as you say, patients like it, right? Patients get
Yeah.
it. So,
Yep.
and they're the only key factor here.
Mhm.
If they get it, okay,
Yeah.
then that's what we have to do.
And I think too, to your point, like, I'm always trying to have that conversation with patients. Like, I always show them this slide that has three little triangles. One says form, one says function, one says limitations. And we
Mm,
all have to know our limitations because I could be the best myofunctional therapist that ever existed, but if I am just really battling that form, that structure, I'm still not going to reach my goals, right? So
yeah.
that collaborative piece is so important. And, one of the great things, with us as myofunctional therapists is we have so much time to spend with our patients. We're seeing them, weekly, every other week, and we're constantly, every single appointment, educating, educating, educating. And to your point, you're like, yeah, this stuff, and the same with all of us, we all have that light bulb moment. Like, I remember my first myo course, and I'm like, wow, this stuff just makes sense. And it does, right? I mean, you have to have an open mind to it. But I think you're so right. And hopefully, if we were to have this conversation in another decade, hopefully sooner, but we'll give ourselves a decade, I really do think that these things will be standard of care. And standard protocols. Another thing that I want to chat about, and I, again, talking to my myofunctional therapy colleagues, I think we have all seen this, and it's a hard conversation to have with our patients. We see some patients post orthognathic surgery, and maybe, the surgery might have even happened, I don't know, 5 years ago, 10 years ago, whatever.
Mm,
And their tongue, there's no room for their tongue in their mouth. And
mhm.
like, how do you go having that conversation with somebody who has gone through this surgery, this traumatic thing, and tell them, like, you don't have room for your tongue. Like, you still need to be wider. You need to be forward. Like, talk a little bit about that. Like, from a surgical perspective, what does that mean might have happened? And maybe there's other outside factors that contribute to a less optimal result, but share a little bit on that.
Yeah, I'll show you a real good history on that. Remember that my mentors, right, Dr. Riley and Dr. Powell, they started. I mean, they were doing jaw advancement to treat very, very bad sleep apnea. Now, remember, in that era, when they first published it, as morbid as that surgery was, okay, the alternative was a trach, it was a hole in the neck. So really, it was a kind of a good thing. Okay,
Yeah.
now I knew um, when I started working with Dr. Riley and we're seeing these patients, at some point, these MMA patients would come back with relapse.
Mhm.
And at that time, initially, I was a little bit excited because we had the hypoglossal nerve stimulator.
Mhm.
So I thought, well, we can really complete that protocol. And we did. Lo and behold, they started showing up.
Mhm.
And after about 15 years, they relapsed back to moderate and we did the hypoglossal nerve stimulator. So this is that's that technology where you have a electrode that stimulates the motor tongue nerve, the hypoglossal nerve, and it stiffens the tongue and protrudes the tongue during
Mhm.
sleep. Now, almost all of them, the ones that came back with early relapse, were narrow. Now, of course, that makes sense because they were not narrow and they got advanced, then they probably did okay long term. So
Mhm.
what's the deal with the narrow ones? And going back to the research that I had done with the sleep endoscopy, it makes perfect sense.
Mhm.
With the jaw advancement, you're going to do a great job with, your soft palatal muscles, lateral pharyngeal wall muscles. That's fine. But the tongue, that's a different gig. And the tongue has to move and it
Mhm.
has to have space. And if you address the AP dimension, but not the transverse, it's tough. And so I'm going to show you exactly that patient. And by the way, for the audience, this was not rehearsed at all. Now I told Brittany, look, I'm just gonna have a bunch of these videos, and whatever we get to, I'll just show it. But this one here, I'll show you this one. So what you'll see here is so down there you can see that's hypoglossal nerve stimulator in action. Okay,
Mhm.
so the tongue kind of this little curl protrudes, and then the lateral pharyngeal wall dilates, and the tongue base pulls forward. The reason why I have this arched maxilla and dome-shaped maxilla up above is that guess what? If it's not wide enough, and you're asking the tongue to do this, there's not space. Now,
Mhm.
this thing is essentially trying to move the tongue, artificially, right? During say, you're training patients, but guess what? If they come back and they have that high arch palate, it's you know what I mean. You still don't have room to do what
Mhm.
you need, and that's a real challenge.
Mhm.
I should add, even though we're talking a lot about muscles, and we still are, but when you look at a dome-shaped palate, one of the other huge part there, besides the tongue fitting, is that with better nasal breathing. Remember that nasal breathing during sleep actually triggers dilator muscles. So if you are breathing nasally and you have enough room in the mouth, these muscles dilate by itself. So it's doing it by itself.
Mhm.
So you really, besides your, the muscular work, breathing retraining is key. But still, again, how do you train someone in this high arched transverse pattern? You want to try to expand them. So, anyways, I've had patients then, and let's say they're in their 40s and have already had nasal surgery and they want the hypoglossal, but I know they were clearly narrow. I would, expand them and then do the hypoglossal nerve stim, right? So I'm hoping that for the patients you see who had jaw surgery eons ago, yeah, they probably didn't get expanded prior to it. Um, and hopefully they're still within an age range that we could do that. A second caveat is then you'll hear surgeons to say, well, that's bogus. I
Mhm.
expanded them. I did a 2-piece Lefort. I did a 3-piece Lefort. If you go back in time, surgeons used to brag about a 7-piece Lefort. Okay. What these pieces mean is that during surgery, you cut up the upper jaw and you move them. And I always say the problem with that approach is that um, only the teeth move to where they're supposed to move to, but the airway doesn't come with you because it's
Mhm.
not one maxilla moving and pulling all the muscles with you. So, you can have two patients. Let's say one got expanded, followed by jaw surgery. The other one just got their jaw chopped up into pieces. You can have two people look exactly the same after surgery, skeletally even look similar, but just look at the soft tissue. Just look at the airway soft tissue. One of them, it's going to tense up. The other one, it's going to go flaccid. And
Mhm.
so, and that's okay. You can still retrain them. But I'm just
Mhm.
going to tell you that, or for our audience, I mean, you might hear the surgeon say, no, 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 I expanded them with multi-piece, surgery. But again, yes, that's the dental alveolar bones expanded. Okay.
What is there like what am I trying to say? Like how do they know what to expand to? Like what are their parameters, I guess?
Well, I mean, a lot of times when you're doing this, you're trying to address crossbites, right? So you
Mhm.
are dealing with maxillary hypoplasia. You're dealing with the maxilla is too small.
Mhm.
And so you're doing these multi-pieces in order to move these dental arches. And you can imagine you have definite limitations to it because, see, the thing about it, and that's why I've always liked to call this, distraction osteogenesis from maxillary expansion, because we're not just expanding the bone, we're
Mhm.
expanding everything. So the soft tissue, and more importantly, the nasal mucosa up above. You can't regenerate nasal mucosa otherwise. It's one of the most expensive, awesome things in the human body. So again, imagine, right? When you do a distraction, you do it over a period of 1 month or multiple months. You're going to grow a lot of all this tissue. When you go in and you just chop it up into pieces, all you're doing is moving the dental arches around. There's no way you're going to regenerate nasal mucosa in 1 hour, okay, of
Mhm.
that procedure, right? So that's the thing. And again, multi-piece surgery is okay, but that's a dental skeletal thing. It's not the
Okay.
whole solution. It's not ideal. And the other argument I would make for colleagues all the time is if you have a child and they're
Mhm.
narrow and they've got breathing issues, okay, and you've addressed everything else, what the
Mhm.
heck do you do? You
Mhm.
expand them. I mean, the solution would never be, all right, let's chop their jaws into pieces. So
Mhm.
we really shouldn't do it to adults. It's the same argument I have when it comes to doing, tonsil and palatal surgery.
Mhm.
With kids, we just remove the tonsils and, whatnot. And even with adults, why are we, after removing the tonsils, snipping the muscles in funny ways and then reattaching them so they're utterly confused?
Right.
So don't create surgery because nature never intended it
Mhm.
to function that way.
Now, I don't know if you know the answer to this or maybe can ballpark it, but what would you say is like the percent of surgeons that treat more to like your protocols than more traditional protocols from moons ago?
Um, I would say, a lot of the surg I mean, all the surgical fellows that I've trained, I think they're very in tune with this. And, if you look at the ENT sleep surgery meetings these days, I mean, there is a ton on skeletal
Mhm.
surgery and I think a lot of them work with myofunctional therapists. And so there is a small nucleus out there.
Mhm.
But I think the more practical route, depending on wherever you are, is you likely have a surgeon or two that you work with, and you just have to find that one ally where you all sit down and talk about it. Now, obviously, podcasts like this, hopefully, if
Mhm.
folks want to share this and just get a perspective, right, they can reach out to you, they can reach out to me. um,
Mhm.
but at the same time, I think those of us who fully believe it, we have to start doing really good cases and showing really good outcomes to begin to then to scale that. And
Yeah.
that's the next phase. Remember, the last 10 years, at least for me, I had to learn all the different surgeries, put them all together, and then
Mhm.
realize, oh, rats, it still comes back to the muscles. Okay. So, but that's all
There is
right,
something to this.
uh, so we have time, in it to really focus on that. And
Mhm.
like I said, just look at the athletes. All right.
Mhm.
I really don't think surgery itself is going to change that much, but the
Mhm.
science of rehab is
Right.
utterly insane. And as you say, it comes, nutrition and everything else, right?
Mhm.
That's what we have to do.
Now, what do you feel, or what do you wish, I guess, more myofunctional therapists knew when supporting like surgical patients? Like, is there anything in
Mm.
particular you can think of?
Yes. I think there are two things. One is more on the practical end, and that's why that research on looking at these exercises and what they're doing to the muscles,
Mhm.
because just from a time perspective, even for the patients,
Mhm.
while the whole protocol of what you guys do is great, but let's
Mhm.
just say that if there are a time or whatever limitations,
Mhm.
can we at least do some of the most high impact ones, right? If it's a tongue issue, if it's a lateral wall issue, can we be more targeted? I would say that's one thing that we all need to work on. And again, that might be a perspective that the surgeon needs to share with you and say, hey, listen,
Mhm.
I think everything else is pretty good. Got to work on the tongue,
Yeah.
or something. Because I think that's one thing. Um, and then I would say the second thing there, so one is kind of defining, right, more specific exercises for one. And then the other really is just the other one is understand the, as you alluded to this earlier, which I think is awesome, the limitations. Look, in the end, it's going to be this. It's going to be a combination of the two. It's form and function, unless of course you're treating a pediatric patient, in which case the function drives the form. So that's lovely. Okay. But if we're talking about folks where the form is done, okay.
Mhm.
Now, in that respect, the surgeons also should know. Let's say if I'll give you a perfect example. I saw a lady recently and super narrow, an expansion candidate. However, the ortho that she had done way back when, they really uprighted all of her teeth, so they're perfectly straight. It allows almost no room to expand, short of doing a lot of bone grafting and everything else to prevent periodontal issues. So now that becomes not so attractive of a large, let's say, dome patient. But
Mhm.
let's just say that we end up doing a very small expansion, because that's, we don't want to make it too difficult for the patient's teeth and everything, all the other movement.
Mhm.
But if we combine that with myofunctional therapy support, we
Mhm.
might just get her over the threshold, right?
Right.
So that's the thing is, um, on both sides, if we understand that form and function, we don't have a perfect formula to say how much of each, but if we maximize the both, and by
Mhm.
maximizing, I actually say on the surgical end, it becomes minimizing. If we maximize you, you can minimize what I do,
Mhm.
and that is actually frequently needed for the patient. By the same token, if it's a very anatomic issue that can be corrected, work with your surgeons on that. Do the prehab, get the form right, and
Yep.
then work on the function. It'll make your life easier as well.
Yes. Oh my gosh, absolutely. And I'm always when really for all patients, I'm not one that believes in myofunctional therapy while they have like for kids even say like a cemented palatal expander
Mm,
because sure, there's other things maybe you can work on. Like some myofunctional therapists will say, well, we can work on breathing or we can work on lips. I'm like, but we need the tongue to be up in the roof of the mouth for those two things. And we have this bulky appliance up there. So I don't really feel we're
mm,
going to be maximizing our time together. And I try to keep in mind that most of us are, we don't take insurance. So I always
mhm,
say to patients, like, I can see you through that, but I want you to know that is going to take your maybe 12 session treatment plan and turn it into a, X amount. And I always say I want to maximize our time together. I am very understanding of people paying for these services out of pocket. So whatever I can do to maximize the time, that's just how I feel. I'm not saying that people that don't share the same view are wrong. But I totally agree with that. Just maximize what we can. And what was the other thing? Oh, tongue ties. That's the last
Yeah,
thing I
yeah,
want to talk about. So
yeah.
share with us, like I just had a past student reach out to me and she was like, oh my gosh, my patient just had jaw surgery and he texted me tonight and told me that they released his tie and she didn't prepare him. And now, because typically we're not starting myofunctional therapy again until they're on solids of some sort. So like
Mm-hmm. Mm-hmm.
6 weeks or so post-op is typically the earliest we start. Um, and so, yeah, so share a little bit about your experience with tongue ties, best times to do them, how they impact surgical outcomes.
Yeah. So yeah, the tongue tie situation fell in my lap in a very interesting way because, again, after CG introduced myofunctional therapy, and at that time, that was my second fellow. My second fellow at Stanford was Surush Zagi. And so he was really all in on tongue tie. And at that time, I said two things. So, we didn't have adequate data yet, but I took
Mhm,
all the experience that I knew from tonsil, soft palate surgery, everything, which, I have a huge emphasis on preservation. Okay.
mhm,
So before we know anything, at least, let's not burn bridges. And
mhm,
so from the very early stage, we would do our tongue ties. I always, we did cold blade, we did just past the mucosa, and then I
mhm,
just took a Q-tip to release the fascia. Obviously, Sarush has taken that field much, much further. But, what I have learned from everything else is that you have to preserve all your muscle. So don't cut into anything, don't scar anything, don't burn anything.
mhm,
You have to keep that muscle working. I'll share an interesting case. It's not frequent that I get a patient where, tongue tie really seems to be like the only culprit, right? Because most of
mhm,
the times the tongue tie situation is this: it's the adult patient with a narrow maxilla, nasal obstruction, history of septoplasty, still has sleep disorder breathing, upper airway resistance syndrome. The tongue can't make it up to the roof of the mouth, and they have huge lingual tonsils, and then the forward neck posture. You tell me
mhm.
if that's not the tongue tie adult patient. Okay.
Right,
Now,
right.
but then I had this guy where it was odd. He
Mhm,
was handsome, beautiful, jaw good, everything great. What the hell? How is it possible that this guy? Anyways, I'll show you his sleep endoscopy. Like I said, this is the end of one, so let's do this for kicks. But I think it's very it's a good teaching case. So
yeah.
that's him. Okay, But I mean, look, the truth be told, not the most narrow guy you've ever seen on planet Earth. Okay, not he was. Oh, sorry, he wasn't one of those. Oops. Let me go back to the right slide here. So, anyways, um, I will show you his sleep endoscopy.
Mhm,
So look, remember collapsibility. Well, nothing's collapsing. I mean, the lateral wall, the soft palate, it's pretty solid. Nothing is closing in, right? Except for the super lazy tongue, right?
mhm.
And it's basically sitting on top of the epiglottis. Air is barely blowing out of that thing. Now, if you see this, yeah, okay, now I believe. I mean, yeah, the whole darn thing's closed. So
Right.
I believe, I believe, But look, everything else is like rock on solid, right?
Yeah. Yep.
Rock on solid. Hey, anyway, we release his tongue tie and take a look at his pre and post. So, and this is immediate. So I'm not saying he's had adequate therapy, but look at that. The tongue pulled forward,
Yeah.
right? Because that's what the tongue does, is a genioglossus muscle. That's what the tongue does.
Mhm,
And with some better training and all, this
mhm.
tongue will move, because right now the tongue's still lazy. Okay. So this is my end of one where the dude literally only had this issue. And it
Right.
remains a powerful before and after. So again,
Yeah.
a lot of care as we deliver it has to be matching, right? Matching the right care to the right patient. I can tell
Mhm,
you, actually, a lot of my colleagues will look at that tongue. You know what they'll do? They'll cut the back of that tongue. I know they would, right? Because that looks like those are lingual tonsils, and you can't do that. But see, those lingual tonsils is not the cause, right?
mhm.
They're a reaction. Just like the big palatine, the big tonsils. They're not, I mean, sure, they're gonna, we often see them as the cause of sleep apnea. But if that were the case, once you take them out, everybody should be cured. But that's
Right.
not the case.
Right.
But a lot of the times, that's the big tonsils are a reaction to chronic mouth breathing, which is a reaction to inadequate nasal breathing and hence poor sleep disorder breathing. Okay, so we got to get back to the original cause. I think CG wrote a beautiful paper with my first fellow Carlos, and the title was "Nasal Breathing is the Ultimate Goal." To the treatment of sleep apnea, and I fully agree with that. So, anyways, so when it comes to tongue tie, my sense is this: just like everything else, it rarely happens in isolation. So, if you're going to treat tongue tie, you want to make sure whatever else that needs to be done, nasal breathing is restorable, maxillary width is adequate, maxillomandibular position in the AP it has adequate tension. Okay, and you better have a myofunctional therapist working with the patient already, as you say, so that post-op you're not dealing with what what the heck am I supposed? And I mean, I think folks would get very, very lost.
Yeah,
In
the tongue's
this.
like a fish out of water if there's no myofunctional therapy
Yeah.
before.
No, no,
It's
no, no. To be fair, if the patient eventually eats and talks and sings,
oh yeah,
they
of
will
course. Yep.
eventually figure it out. But then
Right.
you've lost. Remember that's just the whole purpose of doing this is they come back better, right? Like those baseball pitchers, you come back throwing 3 miles faster. Uh,
Right.
we want them to be better afterwards, not just to get back to baseline, right?
Mhm.
So we don't want to lose out on that opportunity.
It's so funny. I was just having this conversation with another myofunctional therapist. Those patients that have come in with these tongue ties, and you're like, how did you grow that way? How do you have like somewhat of an adequate transverse width? Like, this doesn't make sense with what I know. And I swear, all of those, and that's not all of them, but the ones that I have seen, they have all had a significant tongue tie, like a grade 4. So I don't know if there's something to I don't know what it is, but the patients that I've seen where it's like, whoa, this doesn't line up, this doesn't make sense. It's been all those patients have been a grade 4 tongue tie. So I can't figure out exactly what, but from my experience, that's what it's been, which is interesting.
Well, and that's this patient that I just showed
Right,
you, right? I mean, everything else checks out. And
right.
so for me too, I'm like, you know what? I don't know what to tell you, but I'm going to tell you this. Of all the
Hmm.
findings that I can possibly see,
Hmm.
this is the only issue. And you know what? Of all the complicated procedures and surgery that you could deal with, there is a simple thing that, again, so it's about matching. But no, you don't want to be doing this on a kid with lots of tonsillar hypertrophy or just jawbone is all out of proportion. I mean, you don't want to do that because that by itself is very limiting.
Right.
And so yeah, so form and function, and tongue tie release is no more complicated than that. It's form and function is one step to help restore function.
Hmm.
But you got to make sure the form is somewhat workable. Otherwise, it's an uphill battle for you too, right? It's a
Yeah.
heck of a battle.
Oh my
So,
gosh, absolutely. That's why I'm a big fan of Myo post expansion because I'm like, we're all going to be on the struggle bus here.
yeah, yeah.
Thank you so, so much for this. Is there anything you want to leave the listeners with before we wrap up?
Well, I think remembering the why is always really critical. If you think about all these concepts and ideas we're talking about, ultimately we're trying to deliver the very best care. And then we all realize that complementary care is really key.
Mhm.
More of you. I always say, more of everybody else is less
Mhm.
of me, right? More if everybody else did more, if the myofunctional
Mhm.
therapist did more, if the pediatric dentists do more, the surgeons do less, and that
Mhm.
is a great thing because
Mhm.
ultimately, if surgery becomes the only good option, I
Mhm.
would say surgery is never really the best option, right?
Right.
And that's why I always say, um, two things, right? My own whys, right? I think restoring sleep airway health is a gateway to wellness,
Mhm.
and it defines so much of our lives. And the
Mhm.
way we want to be thinking about it is to approach patients not at a cross section, but to
Mhm.
think about the missed milestones during
Mhm.
growth and development, and that we do our best to recapitulate that. And
Right.
I think if fundamentally we all think that way, it's
Mhm.
inevitable and very organically we'll come to the same conclusions.
Yes. Oh my gosh, beautifully said. I love that. I love that. Thank you so much for taking
Thank
time.
you. Thank you
Game
all.
changers
Thank you,
in your
Brittany.
schedule.
All right.